All right, so we're already live on YouTube. It's a pleasure to be here. My name is Elena. I'm a chief resident here at the University of Copenhagen residents. These are our first, second, and third year residents, our career staff, and Professor Nordgaard. She's a clinical professor at the University of Copenhagen in Denmark. She's the president of the European Association of Fenomenology, Psychopathology, and Psychotherapy. She's the chairman for the Institute of Psychopathology in Denmark and director of ALL-E, the scale for examination of anomalous self-experiences related activities. Clinically, she specializes in schizophrenia spectrum disorders and psychopathological assessment of first definition patients. And the key points for her research has been psychopathology and the psychiatric diagnostic interview from a phenomenologically informed base with focus on the subjective experiences, which is what she will be talking to us about today. So we'll take her presentation, and then afterwards we'll have the questions from the audience.
Well, thank you very much, and thank you for inviting me. So I will use the next around half an hour to introduce you to the concept of self-disorders, which is a subjective dimension of psychopathology. And wow, yeah, here is a brief outline of my talk here. I will start to give you an introduction to the concept of basic self-disorders and talk a bit about how self-disorders can be assessed, and present you with some results from empirical studies in self-disorders. And then I will end up trying to say a bit about what is the usefulness of self-disorders, what can we use it for. Right. But the hypothesis, or the main hypothesis behind the self-disorders, is that schizophrenia fundamentally is a disturbance of the self, or the basic self. And this idea is not new in any way, but it was sort of forgotten and then rediscovered at the turn of the millennium. This hypothesis is well described in the classical psychopathological literature, and it is called different names there, for instance, Ich-Störung, ego disorders, and so on. And the idea is that a disturbance of the basic self is closer to the psychopathological core of schizophrenia, and it is a more consistent trait than, for instance, the psychotic symptoms, which are usually, or in most cases, state phenomena, which is there some of the time, but not all the time. Then the idea is that this disturbance of the basic self is there all the time. And also this, that the basic self-disorders are closer to the psychopathological core. So the idea is that it is, if this is the core, then we have self-disorders, and then above that we have some of the other symptoms characteristical for schizophrenia, and that the self-disorders are what allows for the schizophrenia-specific psychotic symptoms to emerge, and that could, for instance, be for the first-rank symptoms to emerge. Right, so returning to some of the classical psychopathologists who wrote about this, that the core disturbance, or the trouble générateur in schizophrenia, actually is a disorder of the self. And that was, for instance, Bleuler, Kraepelin, Jaspers, Minkowski, Snyder. Many of them described it. I will only refer a few of them here. But Kraepelin, he claimed that a disunity of consciousness was a fundamental feature in dementia precox, and it was linked to a peculiar destruction of the inner links of the psychic personality. And Bleuler described ego disorders among the complex fundamental symptoms. And I'm sure you're all familiar with Bleuler, who was the first who coined the term schizophrenia. And he talked about the fundamental symptoms and the accessory symptoms, where the accessory symptoms were psychosis. And some among these fundamental symptoms were the ego disorders. And later, Minkowski wrote that the madness does not originate in disorders of judgment, perception, or will, but in a disturbance of the innermost structure of the self. Right, so self-disorders, they are a manifestation of an unstable or disturbed structures of consciousness, or a disturbance of the basic self. And then we need to talk a little bit about what I mean when I say self, or the meaning of self in self-disorders, because self is a polysemic word that can mean different, or are used in several different ways. And here today I will distinguish between two kinds of self, and that is the narrative self and the basic self. And the narrative self provides the answer to the question, who am I? And it includes identity, characterological traits, temperamental features, values, attitudes, and beliefs. And it is shaped by my interactions with others and with the cultural symbolic objects such as language. And it is sedimented in my disposition, or what could be called my habitus. And it is a rather nice and sophisticated complex that also entails an understanding of the self's relational and dynamic aspects. And we call it the narrative self because it, at least partly, is a product of the stories that I and others tell about myself. And then we contrast it with the basic self, which is a much more sort of thin or simple concept, because the narrative self is a rather complex structure. But the basic self, that the self manifests pre-reflectively as a certain configuration of experience, and it designates that my experiences manifest for me in my first person perspective. So it's important here to realize that this means that my experiences are given to me in my first person perspective and nothing more than that. So it is a very thin concept. And it also entails that I am always pre-reflectively self-aware. I don't need any reflection to assure myself of being myself. And all my experiences, they are permeated or tagged by this pre-reflective sense of self-presence, or which could also be called autoaffectivity. And it persists across time and changing modalities of consciousness. And by changing modalities of consciousness, I mean, I know when I am thinking, or if I am imagining something, or if I'm remembering something. Those are three different examples of modalities. And this concept of autoaffection can perhaps be explained a bit more, that when I, for instance, touch my glasses here, then I can feel myself, that I can feel the glasses. But what also happens is that I sort of also feel that I'm feeling the glasses. And that is the idea of autoaffection, that it also affects me when I touch something or experience something, because I know it is me who is experiencing. Yeah, and the sense of self-presence saturates the experiential field, and it articulates what is me and what is not me, the boundary between me and not me, or me or the world. And it infuses a first-person perspective with an inchoate sense of individuation. And these basic self-disorders, they are conceptualized at a non-psychotic level, and they have this as-if quality. Of course, some of them can develop to a full-blown psychotic experience, but then we won't call it self-disorders anymore. Then we will call it that psychotic experience that they might be, which could, for instance, be a first-rank symptom. So it has to be on a non-psychotic level, even though some of them can be rather near psychotic. And these self-disorders, they are present before and after frank psychosis in schizophrenia spectrum disorders. And by schizophrenia spectrum disorders, I mean schizophrenia, schizotypal disorder, and schizoaffective disorder. And these are all experienced in the first person's perspective. I guess that is clear from what I have said from now. And this pre-reflective, automatic and self-evident aspects of our experiential life are usually not the focus of attention. It just sort of runs tacitly in the background, but it is always there. I am always self-aware. Right. So if we look at sort of the properties or the, yeah, I guess I will call it properties of the basic self. Most importantly is this ipseity, which means that this is the basic self is what gives us the feeling of mindness to all my experiences and all my actions, that it never occurs to me as a question, is it really me who is sitting here talking, or is it perhaps someone else? I know it and I don't think about it, that it is me and that it is happening here. The basic self is also embedded in the world. There is sort of the self pole and the world pole that interacts with each other. So it is always, or the normal experience of the basic self is always embedded in the world. And the basic self, the normal experience of it is also that it is self-relating. So one can sort of reflect about self-experiences. It is also tacitly given or pre-reflectively given that myself is private and it is inaccessible to others. Others can only know about me what I decide to tell them or show them. Also, the self remains the same over time. So even though I have definitely changed a lot since I was 20 years old, I still have this very clear feeling or experience of being the same person as I was when I was young. And this is also, the self is also experienced as the starting point of all my experiences, because I am sort of the center of all experiences that relates to me. So perhaps it's most easy to demonstrate with visual experiences. So sort of the point zero, or the point of experiencing for me when I see something in my visual field, is somewhere around here where my eyes are, and then out in the sensory field. And the self is bodily bound. I know that myself is within my body, and it is my body. And it is non-spatial, so it's not located anywhere in me, but it is of course in me, but it's not located in the left side of my head or in my stomach or something like that. That is not the normal experience. Right. And perhaps I have to say something about the terminology, because that is a bit confusing. There is only one self-disorder. The self can be disordered or disturbed, and that is what we're talking about here. Then this basic disorder can manifest in a range of different ways, and we often call that self-disorders. And that is, of course, perhaps not the best way of labeling this, but the idea is that it is because it is just manifestations of this basic disturbance. Yeah, and as I said, it can be the basic disturbance can manifest in many different ways, but all of them are ego-syntonic. They are non-psychotic, and they usually have a quite early onset. That is what patient tells us when they have these experiences. They either say, well, I have had them for as long as I can remember. I can't remember a time when I did not experience like this. Or others say, well, it started during my adolescence. That is a typical description. And I will give you a few examples here. A patient said to me, thoughts feel somewhat anonymous, almost as if they were not mine, which of course I know they are, but they feel that sort of they are not saturated by the feeling of me, or this mindness is somehow lost. It doesn't feel like it's anybody else's, but it's just anonymous, and it feels like, yeah, not really mine. So they are not self-affecting in the same way as they perhaps used to be, or as they had been before. Another patient said, "It feels like I'm smaller than my body, as if I'm experiencing the world from further within, like I'm watching the world from a place located a bit behind my eyes." So I guess there are several experiences of disturbed or self-disorders in this quote. One is this, what I said before about sort of the point zero of experience, or the starting point of experience. Here the patient has this experience of seeing out through his eyes, so that he is located further behind than he used to be. And then he also described this experience of having a difference between him and his body. So he told me that if you place me here and my body here, you will be able to see that we are not the same size. So obviously there's something here about this not really experiencing me and my body as one and the same thing. All right, and the last example here is a patient who said, "I can get surprised when I see my own reflection in the mirror. Like, is it really me?" And though I do realize that it is my reflection. So what the patient said here was that when she looked in the mirror, she sort of was so strange that she really looked like this. It was not related to if she liked her the way she looked or not, but she was just that this is so strange that I can look like this, because it is not in any way reflecting how I feel inside or something like that. So every time she looked in the mirror, she got a bit surprised, even though she obviously knew it was her. Right, I have a few more examples here, but these are without quotes from patients. One very typical description is this feeling of being radically different than other people. And what is always important when talking about self-disorders is that you need to go beyond the sort of trivial statements, because in some way we all feel different. We are different from each other. But here we are talking about the experience of feeling different as a human being. Perhaps not really feeling as a human being, or perhaps more feeling like an alien, or maybe not feeling completely alive, or have doubts whether I'm really existing. But it needs to be on this level where I do know that of course I'm alive, and of course I exist, and of course I'm a human being, but it just doesn't really feel like it. And then we already had this description of this experience of anonymity of the thought. Another thing could be perceptualization of inner speech, what in German is called Gedankenlautwerden, where the patient hears her own thoughts aloud in her head, not through the ears, but in her head, typically spoken with her own voice, but that doesn't have to be the case. But it is definitely her own thoughts. It is no one else's thought, and she completely agrees with everything that she thinks. This is her thought. And she can say, definitely nobody else have access to what I'm thinking. No one can hear it. So in this case, we would say, well, it's still in a non-psychotic level, but of course it can develop into a full-blown first-rank symptom as thought broadcast. Right. Oh, another example could be common sense problems, where it is difficult for the patients to sort of pre-reflectively understand the world. Why do other people do as they do? Why do we have sort of these unwritten rules of social behavior and not really understanding this? And this often leads to hyperreflectivity, because then the patient has to think about all these social interactions, or think about why in the traffic light in the street, why did we make it yellow, green and red? Why didn't we choose some other colors and stuff like that, that they can reflect constantly about? But also, what is expected to me? How do I behave? How do I do small talk? Because it simply does not come easily to me, or without any effort to me. It can also be reflected as transitivistic experiences. And transitivistic is this with the boundary between me and not me, or me and the world, so that the patients get some kind of experience of being a bit transparent, that people can perhaps see something just by looking at them. Of course, if the patient are convinced that other people can know about me by looking at me, and I'm absolutely sure that they can know private stuff about me, then we're on a psychotic level, right? So it's on a more basic, or before that. So it's just like, it's like I'm an open book. Of course, I know that this can't be, that they can't know anything, but still I feel sort of transparent. And then the last area that I have here are the solipsistic experiences. Ipse means self, and solo means alone. So it's the self in an alone position somehow. And here the patient often have experiences of being somewhat central in the world, attracting a lot of attention, like self-reference, but not on a psychotic level, but they just have the feeling that there are so much attention directed at me. But of course I know it's not there, but I still have the feeling. Right. So in 2005, the EASE was published. The EASE is a scale for examining these self-disorders, and it is called, or it's an abbreviation of Examination of Anomalous Self-Experience. And it was a collaboration between psychiatrist and a philosopher. And what went behind this, or before this publication, was many and very long interviews with young patients who were first admitted for the first time, and who were all suffering from disorders within the schizophrenia spectrum. And they all sort of gave similar descriptions of this. And there were two research groups, one in Denmark led by Joseph Parnas, and one in Norway led by Paul Møller, who is the second author. And these two groups, they did not know each other, but they actually found the same thing almost at the same time. So, and when each of them published their results, they of course got to know each other, and then they started this collaboration, which ended out in the publication of the EASE. And then they realized that what they have found here with the self-disorders were actually not new. It was just sort of a rediscovery, because it is well described in the classical psychopathological literature. All right, but the EASE contains 57 main items. Some of these items have sub-items. And all the items are divided into 5 domains. And this division into domains, it's only to get some structure, because 57 items is a lot to remember. So it's a bit easier if you have, okay, this is from this group and this is from that group. But there's no sort of special significance to the domains. It is all these 57 items are all different reflections of a disturbance of the basic self. Right. And the psychometric testing of the EASE has revealed that it has an excellent internal consistency, that it has a monofactorial structure, and that it is possible to achieve good to excellent inter-rater reliability among trained, experienced clinicians. The CAPAs, which is an often used statistical measure for agreement or inter-rater agreement, shows that it is between 0.62 and almost 1. And this is along the same lines as other psychopathological instruments such as PANS and stuff like that. When we rate the E's, we usually rate it dichotomously. 0 if nothing is present, if we don't think an item is present, and 1 if we think it is present. Then it is really important when we do the interview, that this goes generally for psychopathology, not just for the E's, but it must be kept in a semi-structured way, and it must be in a conversational way in which the focus is on understanding the patient's experiences, sort of what is the essence of this experience, and dig a bit behind it. To give an example, ambivalence is, for instance, one of the included self-disorders. That's one item in the E's. And I had a patient and I asked her, so what is it like for you to make decisions, simple everyday decisions? She said, well, it can be very difficult for me. And I asked her for an example, and she said, well, if my boyfriend asks me what I want for dinner, it's impossible for me to make a decision. And then I further asked her, but why is it difficult? What happens? What are your thoughts about it? And then she said, because it definitely sounded like she had ambivalence. But then she said, well, it's because actually I'm perfectly aware that I would very much like lasagna, for instance, but perhaps he doesn't want lasagna, and then I don't want to impose my sort of needs on him. And then the phenomenon disappeared, because then it's just sort of insecurity or something, because she had a clear feeling of what she wanted. The idea in ambivalence is that you can't really choose because you want 2 or more things equally much, so it's impossible for you to choose. And if I choose this, what if I rather would have had that or that or that? So, but that was not what she was describing. So it's really important always to try and really understand what is behind this experience. And when I say understand, I don't mean sort of in a psychoanalytical way understand it and make my own ideas what's going on, but a very precise description of the phenomenon or the essence of the phenomenon. Right. And these have been translated into more than 10 different languages, also Portuguese. Yes, and then I will just tell you a bit about some empirical results with the E's. Wow, and time is also running, so I will speed up now. And I will give you the results from a systematic review that I did together with some colleagues, and it was published in The Lancet in 2021. So there have been a few studies since, but they show the same. There is a clear aggregation of self-disorders in schizophrenia spectrum disorders compared to other disorders. It is not that it is not seen in other disorders, but a lot is not seen. And here you can see on this slide, the graph shows, or the figure shows, that in schizophrenia and schizotypal disorder, it is around 20 points that they score on the E's, compared with much less for all other disorders that have been examined. That's, for instance, autism spectrum disorders, bipolar disorder, also healthy controls has been tested, and they score a little bit, around 1. Right. So what has been shown so far, there have been a lot of interest in doing research on self-disorder, so it has been done almost worldwide. And there is no doubt that self-disorders consistently hyperaggregate in schizophrenia and schizotypal disorders, but not in other mental disorders or in healthy controls. And self-disorders also occur in first episode psychosis, in clinical high-risk groups, and in ultra-high-risk groups. And the data suggest that these self-disorder scores might be more reflective of a schizophrenia spectrum disorder than of the severity of the clinical states that they are in. Right, then we were really interested in looking at the temporal stability, because if the hypothesis that these are trait phenomena which are present before and after frank psychosis, then they should have some degree of temporal stability, which the empirical studies that have been done on this also shows that it has. It also shows that the self-disorders have predictive value, because high levels of self-disorders at baseline in follow-up studies have shown that that the self-disorders predict later schizophrenia spectrum disorders in patients who were initially diagnosed with another disorder. And they also predict schizophrenia spectrum disorders in help-seeking young adolescents, and also transition to psychosis in an ultra-high-risk sample. And then there have been a lot of correlations between self-disorders and other variables. And I will just mention a few of them. They correlate with the canonical dimensions of psychopathology of schizophrenia, such as positive symptoms, first-rank symptoms, negative symptoms, disorganized symptoms, including formal thought disorders, and also perceptual disorders. They also correlate with impaired functioning and suicidality, but they do not correlate with neurocognitive deficits or childhood trauma. But for the cognitive deficits, we have to be aware that we have not, no study have included patients with an IQ below 17. So all these were within the normal range. Right, and then the last result here is from a newer study that we published in 2022, where we looked at the sensitivity and the specificity of self-disorders for schizophrenia spectrum disorders. And here we found that if a patient scored 9 or more on the E scale, the sensitivity for schizophrenia spectrum disorders was 0.87, and the sensitivity was 0.86, which is really high. And then we repeated the monofactorial analysis once more in another sample, and we again found that it seems to be one factor of the whole these. So why should we care about self-disorders? Why is this important? Because they are not diagnostic. They are not included in the diagnostic systems, neither in the DSM-5 nor in the ICD-10, and they will not be included in ICD-11 as well. The only place they are in ICD-10 is that one of the criteria for schizotypal disorders, there we can rate some on some of the criteria there we can rate self-disorders, but that's the only place. So you can't make any diagnosis, even though a patient might have many self-disorders. You cannot make the diagnosis if they don't fulfill the criteria of the diagnostic system. But still, it's very helpful in trying to distinguish schizophrenia from other psychoses, and also distinguishing schizotypy from other non-psychotic disorders, and for identifying individuals at high risk of developing schizophrenia spectrum disorders. And also very important is that they are extremely helpful for understanding the patient's experiences. And it is very good for the rapport with the patients. They really appreciate talking with someone who actually knows about these experiences, because often they thought they are probably the only one in the world who has these experiences. So it is very helpful to get a really good rapport with the patient. And of course, they're also important for research because they definitely are a target for treatment research. I think most promising is probably psychotherapeutic interventions. Studies are being made now, but none results yet. Perhaps antipsychotic medication also could be useful, at least on an anecdotal level. It is my experience that it does help sometimes, but no systematic research have been done on it. And then, of course, they are highly relevant for etiological and pathogenetic research. So thank you. I apologize, I was a bit longer than 30 minutes.
Hi, Professor. Can you see us? And can you hear us? Okay.
Yeah.
I will ask that any questions for Professor Yuli, you position yourself here to speak because the microphone wasn't capturing properly. And does anyone have any initial questions? Yes, of course, Professor. Are you senior researcher? Can you?
Well, thank you, Professor, for the presentation. I wonder, you mentioned that the scale does not correlate it with IQ.
Yeah.
We publish a work here. It's the use of an instrument it's a method actually, to improve executive functions in patients with schizophrenia. It's called OGI, Occupational Goal Intervention. And one of the main findings, that unfortunately, our patients have a low IQ. Patients with chronic schizophrenia, etc. So we actually covariated all those, for example, improvement in cognition, but it was need to be covariated with IQ. I wonder if I would like to know what's the average of IQ you have in this systematic review. No,
yeah.
No average, because it differs. No, it differs among countries. It differs, and unfortunately, we think this is an important variable.
Yes, thank you for this question. I think you're right. This is very important with the IQ. I can't say what the average IQ was in the systematic review because far from everybody had done cognitive testing. But from the studies I have done myself, and I have done 2 large studies, one with 100 patients and one with 150, which is of course not a large study, but with the ease it is because it takes quite a long time to do the interviews. And the average for the patients with 100, where I included 100 patients, the average IQ was 105.
105.
Yes. And the other one.
Sorry. 70.
70.
Yeah.
Ooh, that was low.
Yeah.
Yeah.
That's a major problem. 70. That's so. Okay, that's this point. But I think it's very important there's a limitation, I think, but we didn't test. We need to test the instrument here to, for example, see how it works, etc. But I think starting from here is very easy. It's yes or no. I'm going to say, for example, listening to your own thoughts, Gedanken and laut and veld, and say, do you have or don't you have? Probably the patient will respond, yes, I have. or yes, no, to please the doctor, you know? No?
Yeah, but it is a general rule that we will never, a yes will never suffice for a rating. The patient needs to produce an example of their own, which sounds like what we are asking for, right? Because, yeah, you're absolutely right. Most patients are so polite, they really want to please the doctor. But I think this issue about IQ is also interesting because I think it also depends on the condition the patient is in at the moment when you examine them. Because if they are acutely psychotic at the moment you examine them, it will be very difficult to use the ease. The patient has to be in a more stable phase.
Yeah.
And I think also in acute psychosis where the patients can have massive problems with concentration, they will also do poorer on an IQ test that might really be the true if they were in a stable phase. I don't know if you have any experience with that.
No. Thank you very much for that. I'll send the papers.
Yes.
I'll send the papers by mail.
Yeah.
Further questions? If not, then I'll ask the question actually. Here as well. Professor Yuli, sometimes when we see the descriptions for basic self disorders, we inevitably remember experiences that borderline personality disorder patients describe, and even histrionical personality disorder patients describe. I think there's some controversy regarding classification for these things. But anyways, so they really remind me of that at times, and I know that in phenomenology there is a little bit of controversy as well in terms of how does BPD position itself in terms of anthropological existential disorders. I really wanted to know how you see this, if you see BPD as being more like the schizophrenia spectrum disorder, if you think that the way we classify BPD now is really closer to hysteria and this is not really like on the same existential plane as a basic self-disturbance, because on the EASE graphic we saw the non-psychotic disorders all grouped as one, and I would like for you to expand a little more on other personality disorders like cluster B personality disorders.
Yeah. This is a really good question. I think that, well, the basic idea is that what is disturbed in personality disorders in general, not just in borderline, but in general for personality disorders, that is the narrative self. It is not the basic self. And what is disturbed in schizophrenia spectrum disorder is the basic self, and disturbances in the basic self can reflect to the narrative self, which I talked about here, is this much more complex structure, but it does not reflect the other way. So on a theoretical level, patients with personality disorders should not have self-disorders. But then we have the problem with borderline personality disorder, because who knows what is really meant by borderline personality disorder, right? That one of my colleagues, or some of my colleagues, did a very interesting paper where they went through sort of the all the things that borderline has meant through the last 100 years or more, and it's a lot. So it's not that if we get a bit confused what is meant by borderline personality disorder, I think it is quite understandable, because it actually at some points it meant borderline schizophrenia, and it was very difficult. It was with the publication of DSM-3 in 1980 that borderline personality and schizotypal disorders were sort of taken apart. Before that, they were probably very much the same thing. So it is, and then if we look at the ICD-10 with some of the criteria for borderline personality disorder, such as feeling of emptiness and identity disturbance, it is very unclear what is meant by this if it is not from the schizophrenia spectrum. If these two items are probably sort of leftovers from at a time when it meant borderline schizophrenia, but it is very unclear. But I guess my take on it is that if I have a person with personality disorder and I see a lot of self-disorders, of course I cannot, if I can't diagnose them according to the diagnostic systems, I wouldn't do it, but I would keep a close eye and see if they will develop some more schizophrenia suspect disorder, because on a theoretical level it doesn't make sense that the personality traits should lead to this.
Thank you very much.
I would like to ask Professor. Good morning, Professor. Thank you very much for your conference here. I am Paulo Salé, and I work with patients in acute psychotic ward here. And I have some years ago had contact with the EASY scale, and unfortunately it was very complicated to use in patients in psychotic crisis, in acute crisis. And for this reason, we don't have to go ahead with that. But I would like to ask you about, first, if you have some experience or at least some casuistic with patients suffering from secondary psychosis concerning the Distúrbios, self-disturbances. And the other question is, if you have found patients with DSM or ICD schizophrenia diagnosis which did not have self-disturbances, and what do you think about these patients? They are not schizophrenia or perhaps another thing. And the other one is, if you have found some studies concerning the possible relationship between the age scale or self-disturbances and neuroscience studies in terms of, I remember that in neuroscience people talk about corollarium disorder. It's a kind of abnormality concerning the limits of the self and the other, and but concerning more with a kind of neurochemical disturbance, in the sense that the people are not more allowed to get the difference between them and other people and the exterior world. That's it.
Yeah, right. Thank
So
you.
much.
Okay. First of all, I completely agree with you. The ease is not useful in acute crisis of psychosis. At that time, you should not use ease. You need to wait 2 weeks or something like that until the situation is much more stable, and then it makes sense. So I completely agree. It's not useful in the acute situations. I haven't seen any patients with schizophrenia who did not have self-disorders. I simply haven't seen it. As when I started talking with patients about this, they always recognize it. But of course, there are differences in how many manifestations they have. Some have not so many, and some have a lot. But I haven't seen any who did not recognize any of this. Well, the idea in relation to non-schizophrenia psychosis patients that could, for instance, be paranoia or something like that, the idea is that, or the theory is that they should not have self-disorders. We are actually trying to do a little study on that at the moment. It's not empirical, it's more really going through the literature on the subject. And I guess the next step will be to do empirical studies on it. But so far, no, in paranoia, it shouldn't be there because it will be secondary, or what Carl Jaspers called secondary delusions, right? And those are not, they don't require these self-disorders or these different, or these changes in the basic self. So I don't think so. And for your last question about neuroscience, I think this is extremely interesting. And but it is not my field, and I haven't really gotten into these more etiological or pathogenetic takes on self-disorders. I have mostly been on the descriptive level. I've been involved in a few studies looking at the neurobiological underpinnings, trying to search for the self, if we can somehow make a paradigm that so we can sort of scan the self, but still it is I think we are still too far from bridging from the descriptive level to a more biological level, but it's definitely very interesting to look into it, and that is the way forward, but it is still very much in its infancy.
Thank you.
Yeah.
Hello, Professor. Thank you very much for your lecture. I'm a child and adolescent psychiatrist, and I would like to know if, from a developmental perspective, you have some hypotheses of how the characteristics of the basic self develops.
Also an excellent question. No, I don't know. One more the issue here is that when we talk with patients, and we and others have used the EASE, have examined patients with the EASE, and the youngest one has been around 13, 14 years. And they often say, well, I have always had these experiences, but we simply don't know because there are recall biases, right? And the problem is that examining people for self-disorders really requires some degree of linguistic maturity, and also a lot of ability to self-respect. So we don't really think we can use it for children younger than around 13. Perhaps maybe, a very bright or very mature 12-year-old might be, but before that, it's very difficult, we think, but it would definitely be extremely interesting to look more into. But there are a lot of experiences that, not specifically talking about self-disorders now, but as you know, there are a lot of experiences that we accept in children and do not think are pathological, but when adults have them, we do call them pathological, for instance, magical thinking, right, and stuff like that. So it will be difficult, but it's extremely interesting and important.
Thank you.
So, hi, thank you for our lecture. I was wondering if I was thinking about the stigma and the self-disorders, especially in the ultra high-risk groups. If there is some correlation, or if there's a role of the stigma, especially the internalized stigma, on the transition in the ultra high-risk group for psychology.
I'm not sure. So in the high-risk group, if there is any association with...
So if the stigma that these individuals are susceptible, if these play a role in the development of the self-disorder.
Right, so it says, is stigma in it? Well, I don't I'm not sure I can actually answer that question very good, because I don't think anybody has looked into that. But what they have done in the studies that looked at this is that they did the baseline interviews, and then they did the follow-up interviews 5-7 years later. And the interviewers the second time were blinded for what psychopathology was there the first time. So I don't think there is any sort of stigma on the part of the examiners.
Yeah,
But I'm not sure if that answers your question.
Yeah, I was wondering about it because I was reading about stigma, and like when someone is suffering for it, it may be more isolated or maybe more solipsistic, you know. So I was wondering about it.
Right. Yeah. Yeah. Well, but then I think the discussion is more like, is this stigma or is it a part of the illness? Because for me, I would think that if a patient experience, if it's an ultra high risk patient and they experience isolation and having solipsistic experiences, I would think that this is probably an expression of beginning illness.
Okay.
Yeah.
Hi, Professor. Thank you for your lecture. I have a question. You've mentioned this follow-up 5 to 7 years later, and we have this, I believe, like a classical concept from Jasper's of process, and I believe schizophrenia is like the main theme of process. And so my question is, have you seen this with self-disorders, the patient getting worse of the self-disorder, so having a higher ease punctuation or something over the years?
Yeah, we have done 2 studies on 5-year follow-up studies, and they were quite stable, but they actually did have, I think they scored 1 point more on self-disorder, so a little bit more at follow-up. It wasn't significant, but I have seen so not in the studies, but I have seen a few patients who, with the first time, which I just have been a doctor for, so it's more on an anecdotal experience level, but when the first time I met them, they did have some self-disorders, but not that many. And then I stumbled upon them again, maybe a year or 2 later. And then they talked more about, so they had more. And I actually asked one patient about this, because I have a video of her, both when I saw her the first time and the second time. And I said, well, are these new self-disorders that you're telling me about here, is that new, or was it there the whole time? And she said, no, it was there the whole time, but it has become more obvious to me now. So that's the best answer I can give you. Yeah.
Okay. Well, thank you.
So is supposed to be a semi-structured interview, and it's very different from the SCID, structured diagnostic interview and knowing about your work with first admitted patients. Can you talk a little bit on that, Yuli, on these differences and how it is important to remember the psychiatric interview principles?
Yeah. Well, I don't. You're absolutely right. The E's should be used in a semi-structured way, but for me, I think that you cannot assess any kind of psychopathology by using a fully structured interview, because the problem is that you need to know what the patient is talking about, what is in their experience. So if you only ask them a question, and as your professor said before, and then the patient just say yes, then it's just like, it's difficult to know what they're talking about. And it's even worse, actually, if the patient says no to a question, because then how do you require more into this experience without are you absolutely sure you don't know it? You can't do that. So I really think then when assessing psychopathology, all kinds of psychopathology, you need to, of course, ask some questions, but be open to try and understand what the patient is saying and what are they experiencing, and inquire further into their experiences. I think this is really important. Using fully structured interviews, then you risk to get way too little information from the patient, because this also requires that the patient actually, that you're sure they understand your question. And I think that's difficult for a lot of patients, because maybe their experience is, they do not recognize their experience in the way you formulate the question. So it's much more important that if you can get the patient just to talk about their experiences, and then you decide, okay, this sounds like this experience, let me hear a bit more about that. So I think that's a really important point, not just for these, but in general.
Any other questions? Last one. Yes.
Hello, Professor.
Hello.
Thank you very much for your presentation. I have a pragmatic question. How can we be trained to use easy if we want to make some studies with this?
Yeah. Well, that is an important question, because of course you can read a bit about how the scale is used. That will be in the part in the paper. There is a paper, the English paper on these, and I guess it is in the Portuguese translation as well. The introduction to the scale says a lot about how it is supposed to be used. You can also find some videos online on YouTube where you can hear a bit more about it. But then I think it is, if possible at all, to participate in an introductory course. That would be excellent. But of course, it's difficult if there isn't any in Brazil. But then start using it, perhaps being a group, and then discuss it together. Because everybody are absolutely free to use it, but of course the quality will be better the more you know about it. But I think and also then just start with, familiarize yourself with perhaps 10 items, start by using that, and when you feel relatively familiar with that, then expand with 5 more, and then gradually sort of integrate it in your psychopathological knowledge. That would be my suggestion.
Thank you.
So Professor, sorry to monopolize questions, but I wanted you to talk a little bit more about how you see self-disturbances as possible treatment goals, because you mentioned that in the beginning of the lecture. And first of all, do you see self-disorders respond to antipsychotic treatment or other kinds of treatment? And yeah, just basically how you see this, because I'm under the impression that when we treat psychosis, we're treating things that are, let's say, more superficial manifestations of these things, and the basic disturbances are constantly there, and what we see as like negative symptoms and such. So
yeah, but I agree with you. Where I use antipsychotic for if I use it in a patient who are actually not psychotic, but really have problems with the self-disorders, are if they have self-disorders which are very psychosis near. So if they, for instance, have so much self-reference that it is impossible for them to go shopping or take the bus, then it is my experience that a small dose of antipsychotic can not make it disappear, but make it a bit better. But it's only, in my experience, there hasn't been any systematic studies on it. But I do think that that psychotherapy is a way forward. And definitely psychoeducation, you know, just to be familiar with this and know how do I react in these situations, or what situations will make these problems very clear for me and stuff like that. I think that will be very useful, but yeah, we need research in that area.
And in patients that are already psychotic, do you see that addressing the basic self-disorders has like a significant impact in their treatment, their progression?
I don't know. I don't know. We don't have any research on it. So. But it is on its way. Yeah.
Professor, thank you for your lecture. I'm wondering, how do you talk to patients when you realize there isn't basic self-disorder, but it's not yet psychotic? How do you conduct psychoeducation with the patient in this case? What do you say to them?
Well, I will, for most patients, I will just talk with them about that. Some of the experience points in the direction that they have a bit, that the way they do when they think, or their consciousness might, the structure of their consciousness might be altered a little bit. And I will tell them about this and say, well, this might not mean anything, but it can also be what gives you some problems, because we know that it can give problems of making things, some things more difficult. For instance, having problems relating to other people. It can give problems in feeling that life has meaning and finding meaning in life and stuff like that. I will tell them about that, and then I will say to them, well, but a lot of patients who has these experiences, or this slightly changed consciousness, they also often describe that they feel more creative, that they might be more seeing things differently, better at thinking out of the box, and it might sort of open for other positive experiences, but it also have this sort of problem side. And we will just, I won't make it like well, I'm sure you will be a schizophrenic if they do not fill the criteria, but I will talk with them about this. Yeah.
Thank you.
Se alguém tiver perguntas para Fê, a gente pode transmitir também. Or any questions in Portuguese, we can translate them into Portuguese. Any questions?
Just one. Really, just like taking some methods that we got Professor Elio here, who's working with treatment-resistant schizophrenia. Do you think that self-disorders bring something new to the treatment-resistant schizophrenia? Like, does this shed any new light on this topic? Has been like
no, well, I think that it can be helpful. My guess would be, but again, we need more research into that. But my guess would be that these patients would benefit from psychotherapeutical approaches, also targeting self-disorders. I definitely think that, but moving beyond, we need to move on what I believe, right? We need research, yeah. Yeah, but even though they might be severely psychotic, I think they will benefit from that, but we'll see.
Do you think that self-disorders can change our way of conceptualizing treatment-resistant schizophrenia?
No, I don't. I think we are we are far from that. I think treatment-resistant schizophrenia is a problem that we are not nowhere near solving. Yeah, no, unfortunately not. But I would hope so. Of course, it would be great, but I'm not sure.
Talvez opostos. We have working with treatment-resistant schizophrenia for many years. I have published many randomized control trials in ECT, occupational therapy, social training skills, cognitive behavioral therapy. But the main instrument for schizophrenia is the PANSS. So the PANSS is the 30 items, of course, you are familiar with. And I think it's very complicated to. I think the question of our colleague is about the specificity, about the self-disorders in treatment-resistant. But we don't have data. Is there any relationship between the EASY and the PANSS?
Yeah, there is a relationship that the PANSS is examining the sort of the classical dimensions of schizophrenia, and we do know that there is a high correlation between ease and positive symptoms and negative symptoms. But I think I completely agree with you. Why would we use ease for treatment-resistant schizophrenia? The ease is relevant if we have doubts about the diagnosis, and we do not have that in treatment-resistant schizophrenia, right? So but PANSS is a very absolutely good instrument, but compared to the ease, it's very, very primitive. This is perfectly fine for very psychotic patients. The ease are for patients where we have doubts: is there psychosis, and is it a schizophrenic psychosis? If the diagnosis is completely clear, don't use the ease unless you want to understand the patient a bit more. But otherwise, I wouldn't do it. It's for another kind of patients. I completely agree.
If I am wrong, but I think by the description, the instrument is very important and useful for prodromes.
Yeah.
For ultra high risk, it seems to be that I think it's different. To apply this instrument for in the beginning, talking about schizophrenia in the beginning or ultra high risk or prodromes, so there is a confusion in the terminology. And in patients that have established schizophrenia, don't you think so?
Yeah, I completely agree. Yes. I'm terribly sorry, but I'm running out of time. So I need to finish now.
Yeah, no, that's okay. Thank you so much, Professor Yuli. It was such a huge pleasure to have you here, and we hope to be able to bring more people to talk more about schizophrenia spectrum disorders and phenomenological approach to psychopathology to work right around.
Thank you.
Thank you very much. Thank you.